I'll move for the last speaker, who is Marc Struelens, and he came especially for you from Stockholm ECDC to talk about, is Europe well prepared? Marc.
Thank you, Vincent. First of all, perhaps for those of you not fully familiar with the arcane of the European Union institutions, a few words of what the European Centre for Disease Prevention and Control is all about. This is actually a young EU agency with a technical and scientific role to identify, assess, and communicate on health risk related to communicable disease and related conditions. I'd like to stress that this mandate does not include risk management, which is solely the remit of public health authorities in the EU member states with the support of the European Commission when cross-border health threats are of concern for more than one country. This will be indeed a European-centric view of a global problem, but as we know, we have to think globally but act locally or regionally to move this forward. This particular colorful map echoes those of our previous first speaker in this session. Is actually drawn by my colleague Dominique Monet based on one of the recent review by Tim on the global distribution and reports on different Carbapenemases on the worldwide. And perhaps I can see from that world map that Europe seems to be pretty concentrated as far as having a bit of everything. So we know of the biodiversity there that is pretty abundant in this particular region of the globe. Whether this is ascertainment bias result or whether this is just a truly more concentrated regional phenomenon, certainly open for further discussion. What information do we have on a more sort of denominator based on the actual frequency of these organisms causing significant disease across Europe? Well, we have to look back to a very reliable targeted surveillance system called the EARSnet, previously EARS, currently coordinated by ECDC, which collects from all EU member states and European Economic Area member states consecutive isolates for a number of target organisms. These are the data for Klebsiella pneumoniae from bloodstream infection, indicating for each country what is the average proportion of these isolates exhibiting non-susceptibility to carbapenem, such as imipenem or meropenem. You can see that the map looks pretty green overall, which means that in most countries, these bloodstream Klebsiella, in less than 1%, or at least less than 5% in a lower dense green, shading do have this kind of resistance phenotype. One exception being in the southeast with Greece and Cyprus, with higher rates of resistant Klebsiella. So what does that reflect, and how prepared are we across Europe to actually interpret what happened to create this diversity in terms of prevalence of carbapenem-resistant Klebsiella? Well, Greece happened to be very well prepared as far as recognizing such an emerging threat, and this is very clearly illustrated by this graph from our colleague Alkis Vatropoulos, published 3 years ago in Eurosurveillance, which indicated that through the national surveillance system for antimicrobial resistance, and you can see the actual link to this database here, they were able to demonstrate that carbapenem-resistant or imipenem-resistant Klebsiella were not detected in 2001, and then gradually increased, especially among Klebsiella pneumoniae isolated from patient intensive care unit. That's the blue triangle, moving up from 2002 first half, 2002 second half, from 0 to 30%. This was followed by the emergence with some delay in Klebsiella from patient admitted to other type of wards in acute care hospitals across the country. And the last line indicates the proportion of hospitals where reported carbapenem-resistant Klebsiella, which increased, that's the box, from 0 2001 to 70% by 2007. So at least the emergence was readily detected and monitored across the decade. We have a lot of studies out there on the cross-border dissemination on the global scale. And we've heard before from our previous speakers that travel to foreign countries is one risk factor for acquisition of these carbapenemase producing Enterobacteriaceae. This is one example of compilation of studies from Europe and the US indicating that, for instance, KPC producing Klebsiella very much reflect the clonal dissemination of one particular sequence type, ST258, which has been found distributed in hospitals across the continental United States, as well as a number of European countries indicated in green. But first of all, I'd like to point out that in contrast to these very sophisticated molecular tracing studies, we do sorely lack analytical epidemiological studies indicating what is the relative risk of carrying or acquiring that type of resistant organism according to the country of travel or foreign reception of care. Another question is, how serious is this particular dissemination within a country? And I think we should quote here colleagues Hayo Grunman and other experts from across Europe for coming up with a proposal for a staging system to kind of diagnose how severe the penetration and dissemination of this resistant organism actually is taking place in your own country. You probably can't read it, but basically it starts from the stage 1 with just single cases scattered across different parts of your healthcare system, to stage 2, which is basically hospital outbreaks still localized, to stage 3, when you have several hospital outbreaks simultaneously occurring, stage 4, which is really a number of multiple outbreaks going on simultaneously, as was nicely illustrated by Yuda Carmeli in the previous talk, leading eventually to an endemic situation where most hospitals in the country are repeatedly seeing cases, even from autochthonous admission, with that kind of resistance. It's a little bit like cancer staging from the easy to eradicate, limited in situ lesion to the disseminated stage across the whole organism of your healthcare system. Applying this grid of epidemiological dissemination staging, this map can be produced for Europe. This was produced by my colleague Dominique Monet together with the help of Hayo Grunman and colleagues to try to classify not just in frequency of resistance, but at the degree of dissemination according to the national authorities' knowledge. And you can see that irrespective of the color, which is from green to the stage 1, sporadic occurrence, to the dark red, the disseminated endemic stage, with intermediate orange shades for the kind of more local or regional spread level. We also have a lot of U over printed on each country, which indicate that it's likely under detection in many countries. Again, going back to the previous questions, that how well are laboratories able to actually detect and report cases infected or colonized with this type of organism. Another country where there were clear, excellent preparedness as far as recognizing the threat of carbapenemase is indeed the UK. Again, a very famous figure from the very famous paper of Kumarasamy and Walsh groups in the Lancet last year, indicating that things were pretty quiet until 2007 and starting to get worse as far as the number of cases or isolates reported to the public health reference lab in Colindale with carbapenemase producing organisms over 20 in 2008 and over 70 cases in 2009. And indeed, indicated in red, the majority of this increase were related to one particular enzyme, which is the New Delhi metallo-beta-lactamase. In the same paper, it was clearly established that this emergence was multicentric, both in the UK across different hospitals, as well as associated with travel in many cases to the Indian subcontinent and from collaborating centers across Pakistan, India, and Bangladesh, indicating that different parts of the subcontinent had reported such enzyme in different organisms. ECDC got involved into this issue to produce a rapid risk assessment to try and assess how the New Delhi metallo-beta-lactamase was actually of concern to Europe. This is a small chronology of the events, starting with the paper in Lancet Infectious Disease and the very strong global media coverage that really brought that to the attention of the health authorities and the public, which prompted an epidemiological update which was posted a few days later on what was known about its distribution in Europe, very little at that stage. And at the request of the European Commission, we produced the first risk assessment or threat assessment, which was posted on the so-called EWRS. For those of you not familiar, I will explain a bit later what this means, but it stands for European Early Warning and Response System, which is a data information sharing on cross-border threat across the Union. We felt that there was a need for more accurate information than simple media reports, and therefore we performed 2 questionnaire surveys addressed to colleagues in the Ministry of Health across Europe, the national antimicrobial focal points, and colleagues responsible for antimicrobial resistant surveillance as well. The first survey collected a total of 77 cases. This has been repeated a couple of months ago with a total accumulated case of 107 cases reported in 13 European countries. I'd like to give you a bit more data on that. Where do these cases occur, and what do we know about the organism carrying this particular beta-lactamase? So this is the epi curve for the EU, reporting from 13 countries. And you can see that it's been first detected in 2008 in Enterobacteriaceae, E. coli and Klebsiella mostly, with a steep increase of number of cases in 2009, 2010. If you extrapolate from the first quarter of 2011, still going up to over 75 for the current years to be expected. Travel history was available not just from the UK cases, but also other cases, in total 55 of the first 77. And among those, 31 patients had received healthcare or traveled to the Indian subcontinent within a year or months prior to be detected with the organism, and 5 of them had received healthcare in the Balkans. Of note, about a dozen cases were presumably acquired within the healthcare system of the country across Europe. These are the 13 countries so far having notified to ECDC 1 or more cases of NDM1. As you can see, over 50% have been reported from hospitals in the UK, which is effectively quite consistent with more frequent travel history to the Indian subcontinent. About half of these cases were found in isolates of Klebsiella pneumoniae, the other half in another 5 different species of Enterobacteriaceae, notably Escherichia coli, getting second in frequency, about a third of the cases. Even though the majority were reported as simple cases of colonization, sometimes detected by rectal targeted screening for that type of resistant organism, sometimes just in routine, collected isolates from clinical sites, about close to 50% were deemed to be clinically significant, causing different type of infections, including bloodstream infections. And there were some fatal cases as well. So, as of last year, our first conclusion as far as the risk assessment that was requested from ECDC was that indeed NDM1, but importantly, equally so many other carbapenemases do represent a significant public health threat. This obviously due to the limited therapeutic options, genetic mobility indicated by microbiologist researchers, and preliminary evidence that the international dissemination was related to travel and the global healthcare marketplace. There was a clear need for further studies to clarify the epidemiology, not just molecular, but also clinical epidemiology as far as the environmental and other reservoir and mode of transmission of NDM1 and other carbapenemases. From an EU perspective, there was a clear need for enhanced surveillance and preparedness, both at national and EU level, and for rapid information exchange and epidemic monitoring at EU level. And lastly, we also further provided information assessment through a systematic review of the literature on risk factors, detection methods, and control methods. So just to give you a preview of this so-called more long-term risk assessment on carbapenemase carried out by my colleague Anna-Pelagia Majorakos, Aftab Jassir, Frontfola, and Dominique Monet. We focused on Enterobacteriaceae producing any type of carbapenemase, not singly NDM1, and especially focusing on studies analyzing risk associated with the healthcare setting, including patient transfer between healthcare and between borders. We performed 3 systematic reviews. I'll just give you a gist of the preliminary findings from the first 2, which are what are the risk factors for acquisition, and what is the effectiveness of control measures, including screening, targeted control, or general control methods, on decreasing the risk or incidence of acquiring these carbapenemase-producing organisms. And third was about microbiological detection methods, but I will no longer dwell on this one. As far as risk factors, from about 30 analytical studies, most of these actually dealing with KPC, clearly came out as major risk factors, as was to be expected: prior use of antimicrobial agents with the highest risk associated with use of carbapenems, but also antimicrobials as well. Cross-border transfer of patient was repeatedly identified, but again, mostly in descriptive and molecular epidemiological studies rather than analytical case control or cohort studies. And transfer of patient within units of the same hospital was considered to be one of the risk factors for further epidemic dissemination, and certain comorbidities were associated with the acquisition of this organism or infection thereby. As far as the available infection control studies, the first main findings is that out of several thousand papers on carbapenemase, we could identify only 8 studies so far published by the time of the review that looked at infection control intervention effectiveness. And in fact, 7 out of the 8 were uncontrolled outbreak reports and not planned intervention studies. So the evidence body is relatively limited for this particular type of resistance. Of course, you may argue that there's more ample evidence from ESBL-producing Klebsiella E. coli that we can extrapolate from. Most of these studies dealt with settings caused by KPC, single-center studies mostly, and by and large outbreak studies in endemic or non-endemic regions. To make a long story short, the available evidence, even though from relatively low-quality studies, was consistently supporting the effectiveness of performing active surveillance by rectal screening, culture, and or PCR for these carbapenemase-producing Enterobacteriaceae, cohort nursing for these patients who are positive, and contact precautions during care, with, of course, sufficient staffing level to comply with these. Now, how much of that is actually taken on board across Europe? These are the latest updated data from the paper we published in November 2010, referenced at the bottom of the slides, from the latest questionnaire survey conducted by my colleague, Dr. Majorakos, indicating that 16 of the 29 country surveys do have some national plan. They do have some national guidelines for hospital practitioners. 16 countries do have technical guidance on how to detect or perform surveillance for carbapenemase-producing Enterobacteriaceae. In 14 of those, they have a system to confirm and type this organism in a reference lab facility. 12 require notification to the health authorities, and 13 have issued guidelines, either specific or more broad on drug-resistant gram-negative, how to deal this within the acute healthcare setting, with different degree of detail. So there is substantial preparedness out there. If you look at the paper, you can actually link to each and every of these national guidelines, which is available in the vernacular language on their national website. As far as the upstream cause for all this resistance, of course, is inappropriate antimicrobial use, and ECDC has been striving for the last 5 years to try and support EU member states in raising the awareness of resistance being a global problem that needs to be tackled in every hospital by every clinical practitioner. And for that, we are now, for the fourth year now, supporting the organization of the so-called European Antibiotic Awareness Day. And last year, in November, a number of toolkits were produced for adaptation and translation by the member states, indicating evidence-based approach to appropriate and prudent antimicrobial use, including checklist, screensaver, PowerPoint presentation, and other fact sheet that can be used for further education about appropriate antimicrobial use. The other aspect is the international public health and epidemic intelligence system, and I'd like to conclude with a few comments on that dimension. At European level, in addition to the system organized by WHO on the global level, we do also have a dedicated information exchange system. But first and foremost, I think we should recognize that where information should be exchanged is between healthcare practitioners on the emitting end and on the receiving end, so that any patient transfer would require ideally appropriate clinical information to receiving healthcare facilities when transferring patients colonized with this extensively drug-resistant organism. We've heard before that admission screening to detect early on this colonization status is of essence if you want really to contain transmission and prevent outbreaks. And higher level exchange of information among national public health authorities and potentially other experts, reference laboratories, is being supported by ECDC in 3 channels. The first one is the official channel, which I've already referred to, the EWRS system. Another one, which I'll introduce to you, is the so-called EPIS Intelligence Information System, and we do have already quoted our epidemiological bulletin with rapid publication track for outbreak report. So what about the early warning and response system? And what about the epidemic intelligence information system? In a nutshell, the first one, which has been established prior to ECDC, is now operated technically from ECDC, but it's really informing how the European Commission can actually exchange information with member states' authorities. So it's a formal notification system at EU level for verified communicable disease-related health threats with a potential risk for other member states. The scope covers 49 diseases and conditions under a legal definition called Decision 2119, which dates back from 1998 and has been updated since with new emerging diseases such as SARS, for instance. The focus is really to exchange rapid information on verified threats requiring implementation of coordinated measures, such as been going on with daily telephone conference, for instance, for the current enterohemorrhagic E. coli outbreak taking place across Europe now. And these involve public health officials on policy level. On the other hand, a new kid on the block, which we are developing, is the EPIS, which is provided for informal exchange of signals. So it's really any communicable disease, unverified threats. Experts can exchange information, suspicious events, discuss among themselves what should be done, how the investigation is going on. So this is voluntary participation. And by the end of this year, we should try harness this system also for antimicrobial resistant organisms. EWRS has been used for extensively drug-resistant outbreaks, at least on 3 or 4 occasions, but only a few member states have actually taken the system for sharing information so far. So we hope by opening the EPIS platform, we'll have more early exchange of information. So to conclude, is Europe well prepared for the threat of carbapenemase-mediated resistance? I think we have clearly seen from this whole session and other papers at this meeting that this is a major global threat which does not exclude Europe in any way. Risk factors like for other multi-drug resistant organisms include immunocompromised patient, exposure to healthcare, antimicrobial use, but also transfer between facilities, including across border, and sometimes simple travel to other parts of the world. Measures to prevent spread include active surveillance, cohort nursing contact precautions with some preliminary evidence, but few planned intervention studies to validate those. A majority of EU member states do have national guidance in place, whether it's a fully comprehensive plan as was advocated by Yehuda Carmeli and the group of ESCMID experts earlier remains to be clarified. And we are trying to support this technical information and coordination by soon publishing the systematic review conclusions and guidance documents, and to provide as a pilot this new EPIS information exchange platform for application to signal exchange on emerging extensively drug-resistant pathogen. I'd like to stop here and would like very much to thank my colleagues in all member states, national antimicrobial resistant focal points, antimicrobial resistant surveillance contact points, as they are called, as well as all the microbiology, infection control, infectious disease experts who have been extremely committed to exchange information and share practice to deal with this challenging problem. Thank you.
Thank you very much, Marc. We can take some questions. Yes, go ahead.
Thank you. Is there any evidence that the acquisition of these multi-resistant traits have an effect on the fitness or ability to invade of these pathogens?
Sorry, I didn't quite capture your question.
Is there any evidence that the multi-resistant genotypic traits of these organisms had an effect on the fitness or ability to invade?
I'm not sure I'm the right person to answer that, but I'm sure Tim Walsh will have the opinion to offer some data. Tim?
We have some lab data to suggest that they don't have any significant difference in virulence, but Tim may have other different.
Our data largely agrees with Yehuda's that they seem to be persisters, but at the moment, from the data that we're getting, they're not particularly pathogenic.
Lorene Herwalt from Iowa. Fortunately, I live in a very low prevalence area right now, but yeah, fortunately, I don't think the corn barrier is going to last very long. But in the U.S., CLIA has made the recommendation that labs no longer look at the mechanism by which gram-negatives become resistant. And obviously there's some experts here in dealing with some of these organisms. Is this going to hamper our ability to control spread? Is this problematic?
I personally think it's terrible. I think that maybe the justification not to test for mechanisms in order to determine treatment may be justified, and I think that we can even discuss that. But clearly in infection control, we are aiming the mechanisms. We don't care about the MIC. So it's the wrong decision.
Thank you.
I agree.
I agree also.
Yeah, much the same as the first person. I'd probably like to question Tim Walsh on this maybe. We saw a high rate of colonization in the NDM1 isolates that you'd shown, and in India it's much the same situation. There may be colonizers as well as. So probably much the same question that do we have studies, and we've talked about this before, but do we have studies or anything to predict as to how many of these colonizers would eventually turn into infections? Can we do something about it? Are there markers?
You can do the first study in India.
Yeah,
looking
we
at
can.
colonization.
But have any been done before?
No.
Yeah,
No, absolutely not. With respect to NDM, we have no idea of carriage. And once we have, once the carriage is established, we then have no risk factors of infection. And it's such an important thing to do, and it has to be done by somebody in India. Absolutely.
I would like to comment about the KPCs. What we know now that the half-time of carriage is about 3 months, but there are some who remain colonized for years. And we know that in a hospital setting, among those who are found positive on admission, about 15% of them will develop later a significant infection during the same hospitalization with these organisms. I'm sure 15. I'm sure it's quite different if it's in the general population. I'm sure that the attack rate will be much lower.
So you mean that the ratio colonized per infection could be around 6, something like that?
Yeah, I would say so.
If I may add, given the genetic mobility, I think it's been shown already in environmental samples and in vitro that this plasmid can move into bona fide human pathogens such as Salmonella and Shigella. So this opens, of course, many questions for the future that needs to be carefully characterized.
Thank you.
Since we all seem to agree that the use and abuse of carbapenems really led to this, at least partially, should we have rules at the national levels that carbapenems should be restricted to be only used by the specialist, the same way only oncologists prescribe chemotherapy, for example? You know, I think we've reached a level, it sounds like all over the world, that we're dealing with a big threat, and infection control practices alone might not be the only solution to control the spread. So how do you feel about having national policies about the restriction of use of carbapenems?
Well, thank you for this point. It's very essential that beyond infection control, there are indeed good clinical practice guidelines to use antimicrobial agents in the most prudent, appropriate way. And in many cases, this may imply restricting use if there is overuse of carbapenem drugs. So absolutely, whether this should be done at national level or local practice level should, of course, be decided together with the professionals, because some of the actual guidelines probably need to be tailored to the local epidemiology even further down than the national guidelines. But both can probably be of help in this. I think in Europe there is good progress on both sides, as far as the local clinical guidelines and national general guidelines, that this should go in that direction.
So, if I may add something, it's time to rediscover drugs active against ESBL Enterobacteriaceae, totally forgotten. For instance, cefamycin. And I cannot understand why inhibitors are not more oftenly used for ESBL-producing Enterobacteriaceae, and many clinicians jump immediately to carbapenem. So, and also phosphomycin and nitrofurantoin, as said before. So maybe our microbiologists should do something in order to discourage our colleagues to use as a first shot carbapenem and to curb a little bit the decision to cefamycin and beta-lactam inhibitors.
I may have a dumb question, but do you know of any experience regarding gut decolonization, if there are any possibility for high-risk patients at least?
I think there is one small study from Israel that was presented last ECAC with, I think, some success. I know that there is another ongoing study also in northern Israel, and I'm not sure what are the results. I must ask everyone who does such a study to do it very carefully, with very careful monitoring of any emergence of resistance to the agents that are used.
If I can add, one of the most tempting drugs could be colistin. But we need colistin as a last-line drug. So the choice is quite...
At least in the available literature until last year, there was not a single gut decolonization study on this particular type of resistant organism, but there were 2 studies in which body disinfection on a twice daily basis in intensive care patients was part of multiple interventions. So it's difficult to disentangle the possible effectiveness of that decontamination, skin decontamination procedures from other control measures from these studies.
I can say that if you are living in a country where you truly don't see those strains, and you have a transferred patient into your burn unit who's a carrier, it may be a good idea to do digestive tract decontamination. But if you're seeing constantly those type of patients and you will put a lot of pressure, at the end you'll end up with resistant organisms.
Yes, we should remember MRSA, MIPERSIN experience.
I wonder if any of the speakers have any comment on, so I guess the converse of gut decontamination would be gut recolonization, and if you have any thoughts on data from the human microbiome studies of the intestinal flora, and whether or not recolonization by, say, fecal transplant may be something that can be considered as one of the tools in the future.
If I may just speculate on your provocative comment, I think it makes biological sense to consider that as potential innovative approach, but I would think that the main challenge would be to find the donor with purely wild type and virulence-free microbiome.
Yeah, we'll have to go to Iceland to import stools from Iceland.
Absolutely.
Could you go?
Thank you.
Okay, so Yehuda and myself, thank you, the speakers and everybody for staying so late in the room, and have a good lunch.